So thank you so much for joining today. My name is Olivia Alford. I'm the director of the Delivery System Reform Unit within the Office of MaineCare Services. I've been on many of these calls today, and today we are spending our time together going over where the proposed rate models are for crisis resolution and crisis residential services as they are currently defined in Section 65 of the MaineCare Benefits Manual. So we actually just met, was it 2 weeks ago, perhaps, with you all to talk about some of the initial data we received, which was one source of information. Other sources of information were used in creating proposed rates that Stephen is going to walk through today with everyone. And then this will be followed by a public comment period up until December 9th, when comments can be submitted on the proposed rates back to the department via Burns and Associates, at which point we'll look at those comments. And again, we'll talk about this more later, but a really important process ensues where we look at any changes that might need to be made based on those comments. We know that many of you have been involved in these processes with other services and are getting very familiar with them. So that will be helpful when Stephen starts to go through the results from today. And also just want to remind folks that what we'll talk about a little bit today too is that, again, this is about our obligations under other legislation and our intent to update rates when appropriate for January of 2023. So 6 weeks, 5 weeks from now, lots of work to get there between the next 5 weeks. There's plenty of work that you and our teams are working on to think about broader reforms, which we will not be discussing in detail today. We'll be picking up in the new year. So I think that will come into the conversation today. I'm going to remind people we are focused on the current services, rates for 5 weeks from now, and seeing what we can do. Stephen, do you want to say some opening remarks about the process before we jump into the crisis resolution?
No, I think starting there is a great place.
Okay, great. So one of the things we just wanted to start off and be really clear on, as I alluded to, is that maybe some of you anticipated this as well. When we looked at the crisis resolution rates, your current rates in comparison to any data that you provided, in addition to a lot of other data that's been collected for behavioral health services, and in addition to the rates, the information collected back in 2015, when there was a different rate study for crisis resolution services, the same results came back, where the data does not support a rate increase using the current service model. So that may have been something those of you who have been around for some time, longer than I have, anticipated. So we are absolutely not looking to reduce your rates, of course, for January under the current service model. We are not permitted to do so, nor would we want to under the current maintenance of effort requirements that the department is held to through some of our federal funding. So we are not going to propose a rate for you to comment on for crisis resolution services for 1/1/23. The rates that we have are lower. We're not proposing those. We're not asking for you to give feedback on those. What's really important is that you all know that we are very focused on the new model. Part of what I think is happening here, or we all know is happening here, is that the rate structure we have now reimburses for certain services for a slice of what could be for crisis response services in the community. So it's a combination, we think, of how the current service is defined and delivered, what is the history around the statewide crisis line and other crisis response costs that used to be in part of rates and now are not. We know that you are receiving funding from different sources, such as our state funded contracts. It is a picture that needs a comprehensive review. And as we go into the new service model, that's really what we're looking to do, is to create a more sustainable, comprehensive, rational reimbursement for mobile crisis services or community-based mobile crisis services. So we're really committed to that process, and it cuts out this step for 1/1. And just want to know that we are very committed to the redesign, and we will be picking up with Burns and you all around building the rates for the new model in January. So we have continued that work internally. You have provided lots of feedback during the process. We are able to pick that up in January to start building those new rates. We anticipate being able to roll out the new model, at least propose a new model fully in spring of 2023. So we're not thinking years out, we're thinking next year. We want to get all of this wrapped up, new service, new policy, we'll have proposals before then. That's the timeline we are all pushing toward. So just want to pause for a second here, see if this was expected, that there would not be that the 2015 kind of results were similar to what was produced now, and that folks can stay on board with us as we look to really think about a different way to reimburse for crisis services.
Hi there. I had you had cut out for me for just a few seconds. What is the timeline that you're looking for the reform?
Yes, so we hope to have it effective by late summer 2023, next year. It would be proposed in spring 2023. Just, the rulemaking process takes a number of months. So that's what we are shooting towards right now, working towards.
And also, so with the rates for other services that are that have staffing requirements that are similar to us, are their rates going to match ours? And so we're not fighting over the same people for our service, or are we potentially looking at, because we're not raising our rates, that we may be losing our staff to other programs that can afford to pay them more?
Well, I'll let Stephen speak to that a little bit, because the data, again, based on the current service model, sort of things kind of contemplates that in a different way. Stephen, if you want to talk about what we kind of saw with the rates as they reflect current staffing wages.
So we received a little bit of input into our provider survey about the wages currently paid to folks who are providing mobile crisis services, particularly that MHRT CSP position. And what was reported to us is in the ballpark, although slightly less than what we've built in to the rate models that we're currently going through public comments on for other section 65 services. So already the provider survey data suggests there's close to parity, although it is true that there is a little bit lower wages being reported here for these services than what we've built into some of the other rate models for MHRTCs.
Stephen, I guess I was thinking too, though, we had discussed that even if we updated those rates, that wasn't going to result in a higher rate for this service based on all data available. And looking at how we even derived the other rates, there wasn't a situation where we were going to be able to produce a higher rate than what currently exists for this service.
Thank you, Olivia. Yeah, so Olivia said what I probably should have said a moment ago. So when we were working on developing a rate model, because it's not as if we didn't spend time and effort on that, we did. We didn't ask you to participate in a provider survey when we had expected to use the data, but as Olivia has mentioned a couple of times already, when we build the rate model, even building in that small premium on wages compared to what's reported to being paid currently, the rate itself, the overall rate, would have been a fair reduction compared to the existing reimbursement. So again, even a rate model with those higher wage assumptions would have been disadvantageous to the provider community, which is why that rate model has been shelved pending the broader conversation about the redesign of the system.
And so we I guess a logistical question. So we're not presenting rates today. You will have an opportunity to comment. There's no rate to comment on. Of course, you're welcome to comment on the lack of a rate for January. But again, we really think our best option here is to reform the service, cover more costs within the Medicaid model, be more comprehensive, think about paying in a different way so that you're able to deliver the high quality, accessible service that we all want to provide to Maine people. So I don't know the short term. Of course, we can't predict the short term implications of this, but they're similar to 2015. There really isn't a way for us to propose a rate based on any of the standard processes we use that would make sense in the short term for this service. Anyone else from the department want to say anything? Otherwise, I think we'd like to spend some time. There is a rate increase. There is a rate increase based on, again, not just your provider survey data, but a lot of other information that was able to be derived for crisis residential services, just to cut to the end result there. And I think Stephen would be able to walk us through what happened on that service.
Great, thank you. I'm going to share my screen, and in lieu of a lengthier PowerPoint presentation, I just have kind of a one-page overview of the process and the conclusions for the crisis residential services, which is not what I'm sharing at the moment. Olivia, am I sharing a Word document that says draft rate model review towards the top?
Yes.
Right, thank you. So because many of you have, or all of you have at least been invited to the previous meetings where we've walked through the process, you know, the stages that we go through, data collection, or excuse me, background research, data collection, rate model development. And in the interest of time, I don't want to start from the beginning, but we did think we'd just provide a quick overview for those of you who may have forgotten about what it is we're looking at, what it is we're trying to accomplish, and then we'll hit some of the highlights of the rate model design, and then I will walk through the detailed rate model like we always do as we open up a public comment process. So again, and Olivia already mentioned this just a few moments ago, when we develop these rates, we're looking at information from a variety of sources. So our intent here is to ensure that we're reflecting the reasonable costs that providers are going to incur to deliver services consistent with the state's requirements. And so that always begins then with a review of what those requirements are. We do want to acknowledge, as Olivia already has, that some of those requirements could change as part of this broader revamping of the crisis delivery system in the state of Maine, but we wanted to build rates that are compliant with those other legislative requirements based upon the services as we find them today. And so we begin with a review of how crisis residential is defined in section 65. Whenever we're doing a rate setting process, we endeavor to be inclusive of stakeholder input, particularly from providers, since you have, of course, the best sense of what it takes to deliver services and the costs associated with doing so. And so we conduct a provider survey, we have a public comment process. There's been one or two other meetings during this time, and certainly I know the department's engaged you on an ongoing basis to talk about that broader redesign effort. As it relates particularly to the provider survey, which was the topic the last time we got together, for residential services, we got information from 3 providers. Of course, this is a small provider network, so we certainly don't mean to be dismissive of what we received. And in fact, those 3 providers represent 45% of the volume of services as measured by claims. One of the challenges that arose, and I think I touched upon this a little bit when we presented those results, is that there was a fair degree of variability across those providers. So when you have a relatively small provider universe to begin with, and not everyone participates, it's hard to determine what is most reflective of the what is typical or what is desired within the system. So for that reason, and at least further compelled by that reason, was looking at information from other sources as well, which is always part of our process. One of the things that we did take a look at is the data and the rate models we collected from the previous survey, which was back in 2015. For those of you who recall, we did go through the development of rate models for both mobile and residential services at that time. We had a public comment process. We had a number of meetings to talk about that. And although not implemented, we did finalize those rate models. So at least they had gone through a fair amount of vetting, both internally and externally. We want to certainly recognize that costs have increased over that period of time, but it did at least provide some additional insight into things like how programs might be staffed. And then again, folks have heard me talk about this. Anytime you've been involved in a rate study that Burns and Associates has worked on, we also look to information that's published in other sources independent of what is being reimbursed currently through the main care system. So for instance, when we're setting wage assumptions, we look at what the Bureau of Labor Statistics reports folks who are doing similar work are earning across the state of Maine, specifically within that occupational classification. A really simple one is when we're building a mileage cost in the rate models, we use the IRS's standard reimbursement rate, et cetera. Of course, that takes us to where we're at here today. We've worked through those first two stages of our process: background research, data collection, and analysis. And now we've developed draft rate models. And that kicks off the public comment process for us. So the models themselves and supporting documentation will be available on the website that we've been using. And that encompasses the broader review of targeted case management and behavioral health services. So you'll have the link there. As Olivia has already mentioned, but I'll reiterate, we're accepting comments in writing through December the 9th. Please submit them to my colleague, Carl Matzinger. You should have his email from the provider survey invitations or the back and forth that went on with the survey. But if not, here it is on the screen. And certainly if you're not writing it down, it'll be on the website. And of course, everyone at MaineCare knows how to get a hold of us as well. In terms of the process for public comments, we will be obviously reviewing everything that we receive and putting together a summary document wherein we say, these are the comments that we received, and we provide a response also in writing to each of those comments. If we make a change to our proposal, we provide the explanation of what that change is. If we don't make a change, we provide our rationale for not having done so. As Olivia said, as you've heard on other presentations, for those of you who've been involved in any of our other rate setting projects, this is a meaningful process. It's not simply to check the box to say that we've done it. To this point, I think our rate studies have always included some changes made in response to public comment. So this is something that we in the department take very seriously as a value added portion of the work. So certainly looking forward to getting that feedback from you here over the next couple of weeks. In terms of the highlights of the rate model design, a couple of things I want to share before I get into the weeds. The first is what we have proposed is a single standardized rate. Of course, today there is different rates for some providers. We've, again, through our process, made some assumptions about what we think is the typical or average cost of delivering residential services. Certainly acknowledging that in this field in particular, what is typical can look different from one day to the next, but over time, we've tried to build a rate model that reflects that, the ups and downs, so to speak, of service delivery and associated expenses. I do want to point out that we don't have separate rates for adults and children at this time. So when you look at some of the key assumptions, like say staffing, we're assuming that the staffing levels are the same regardless of whether or not a given program is serving adults or children. But as with everything else in the rate model, that's subject to public comment. So we don't feel that we had enough data to support a differentiation at this point. But if you have data that you can share with us that provides a justification for doing so, that's certainly something that we will consider. Here in a moment, I'll walk through the cost assumptions themselves line by line. But for those of you who like to jump to the last page of the book, the rate model itself is coming out at about $677 per day, which is a fair increase over the existing rates. Obviously, the magnitude depends upon where you're starting at, and we have some rates that are closer to $400 and some that are closer to $600. But nonetheless, the proposed rate is higher than all of the current rates for providers. So with that, I'm going to pivot to the rate model itself. So once again, I think many of you are going to be familiar with the look and feel of our rate models, a series of small numbers and yellow boxes. Starting at the top, the first thing that we always focus on is the cost of the staff who are delivering the service, whether it's a residential service or a home-based or community-based service. That's always where we start, because that's always going to be the single largest expense that providers are incurring for these types of services. And when I say these types, home and community-based services broadly defined, differentiated from, say, a residential service or a institutional service like a hospital, I should say institutional like a hospital or a nursing facility or the like. And so for the frontline staffing, of course, we're benchmarking that against the MHRT1 requirements. So a couple of points, some of which tie back to the question that was asked during Olivia's open remarks. We are standardizing assumptions for the most part across these sections 13, 17, 28, 65, 92 services. So if you look at other services with an MHRT1 requirement or staffing in section 65, like CRS, for example, we're using the same wage assumption. And that is something that we're trying to be very mindful of, that there ought to be parity when we're looking at the same staff requirements, unless there's a good reason for doing otherwise. And there are some of those issues that have been brought up in public comments that we're working through right now for that broader behavioral health rate study. But for MHRT1s, if you look at what we've built in for other services with that requirements, we're at a $20.40 per hour wage. And I'll come back to that here in just a moment. And then for the benefit rates, we're left with an assumption of benefits equaling 33.8% of wages, which is based upon a series of other assumptions related to health insurance and FICA and unemployment insurance and the like. Meaning that the hourly cost of an employing an MHRT1 payroll, wages plus benefits, is a hair over $27 based upon our rate model. From there, we want to take into account productivity, which is how we measure the relationship between total hours worked and hours worked actually providing care. So in a residential model like this, we're assuming that folks, when they're on site, are generally speaking available to provide care to the residents of that home. And so you'll see that productivity is going to be a lot higher for any residential service than it's going to be for a community-based service. So for example, if you look at community-based rates, we have travel time built in because you're going from the home of person one to the home of person two, but you don't have those similar sorts of responsibilities in a site-based or residential model. But a good example of when staff are being paid but can't deliver services is if they're on paid leave, right? So if you're on vacation, you're still being paid for those hours, but as a provider, the position needs to be backfilled, right? So if Stephen goes on vacation, you're gonna have to bring Carl in to provide care to the individuals during Stephen's vacation. So you'll see in a 40-hour work week, we're assuming that folks are available to deliver care for about 34 hours per week on average, just shy of 34 hours, with the balance of that time being taken up by PTO, training responsibilities, fulfilling those training requirements, and employer and one-on-one supervision time. So that could be attending a staff meeting where you're unavailable to provide care, sitting down with your supervisor for a counseling session and the like. After we account for productivity, we need to inflate that hourly staff cost, right? So the cost out of pocket for the provider, so to speak, for every hour that somebody works is that $27. But because you have hours that don't go directly into the payment model, right? The PTO hours can't be counted towards meeting any staffing expectations. We need to inflate that assumption so that we are covering those expenses. And all we do in order to accomplish that is calculated productivity adjustments, which is no more complicated than dividing the total hours worked, 40, by the number of quote unquote billable hours, in this case, just less than 34. That product is 1.18. We multiply that 1.18 by the hourly staff cost of $27.30, and that gives us a cost per direct service hour of $32.21. One final point before I move a little bit elsewhere in the rate model packet for just a moment. But as you can expect, there are a couple of key assumptions in the rate model, and this next section is certainly one of those most integral, or at least most impactful assumptions, and that's how much staffing we're building in to the homes. And so you can see that we're funding this on a per bed basis. And what we're assuming is that during daytime hours, staffing is 1 MHRT for every 2 beds. And during the overnight hours, it's 1 for every 3 beds. And so mathematically, that works out on a per bed basis of 56 hours for the daytime hours and 18.67 for the overnight hours. As I mentioned during my opening remarks in that one-page agenda, we do understand that that is going to vary from day to day, month to month, individual to individual based upon their needs. But we think, at least in the for the development of this initial rate model, this is a reasonable representation of what staffing would typically look like. The total amount of funding that we've built in, as you can see, is about 75 hours per week per bed, which compared to the limited provider survey results that we have is a bit of a premium. So a little bit more staffing than what was reported through that provider survey. So what I wanted to jump to before I wrap up the rate model itself is just where some of these other figures came from. So I mentioned 2040, I mentioned 33.8% for benefits, but I wanted to make sure you're aware that there's more detail that justifies those figures. And so briefly, as I mentioned in my walkthrough of the agenda, we use the BLS to set our wage assumptions because it is state specific, it's across industry, so it's not limited by what your reimbursement is today, because we know that your costs are largely going to be constrained by the payments that you're receiving. So we want to look something that's not just limited to main care providers that, or not just limited to crisis services, but that is more broadly defined. And so we use the BLS data to capture that information. What you'll see on the screen, which I'm not going to walk through in detail, are BLS classifications, the typical educational and experience backgrounds of folks within those classifications, and then various wage data points that the BLS publishes. And so they don't just publish a single wage, they have wages at the 10th percentile, which is the low end of this pay scale, up to the 90th percentile, which is the high end of the pay scale. This information is published once per year, which means, and it's always published a little bit in arrears. So it gets published in every March, it reflects the previous May. And so we wanted to bring it current, and by current, that means we wanted to bring it to the midpoint of the coming calendar year, which is July of 2023. And so we also wanted to recognize that wages have grown more quickly than is typical here recently. So the adjustment that we made to our rate setting process here over the last year or so is not just looking at the 10-year average of wage growth, which is what we've historically done, but looking at how much wages have grown over the past year, using that to fund 1 year of wage growth, and then going back to the typical 10-year average for the remaining months. Because although it's certainly true that folks have gotten a pretty, in many cases, hefty pay raises, we don't think it's reasonable to assume that year after year, people are going to be getting 10% pay raises. And that's not what the data suggests when we actually look at not just the specific source that you can see cited here, but also other sources published by the Fed and other observers. So in short, what we're doing is we're increasing the BLS wage data by about 13.5% to bring it from May of 2021 to July of 23. In other words, we're assuming that over a 2-year period, approximately, folks are going to have a 14% or 13.5% increase in their pay, which is all this table finds. The first table is the BLS's data. This table is the BLS's data with our inflationary adjustments. And then from here, we pick the occupation that we think is the best representation of the staff qualification. So for an MHRT1, obviously that's kind of a main specific nomenclature. There is no occupation called MHRT1 or MHRT within the BLS data set. Instead, those folks are almost certainly classified as psychiatric aides, that more generic classification that is used in the BLS to cover the multitude of job titles that a given state might use. And so we think that's the best representation of the MHRT1 requirements. And again, that's similar to what we've done for other Section 65 services with that staff classification. This table is the mathematical culmination of the previous. So we line up the BLS data inflated for wages, the occupation or occupations that we benchmark each job title to, and then this shows you what that result is. So for an MHRT1, you'll see the data suggests a range of 1640 to 2650. For this rate study, as with almost all of the rate studies that we've done in Maine and elsewhere for that matter, we're using the median, which is that midpoint wage. So some folks, more specifically, half the folks in a job title are expected to earn less, half the folks in that job title are expected to earn more. This is meant to be that average paid wage. In comparison to what was reported in the provider survey, this is, again, a bit of a premium. The average reported for those folks who participated was about $19.50, so a little bit north of what was reported in the survey. Then the last point I wanted to make before I get back to the rate model itself is what goes into the benefit package. So although we ultimately convert that to a percentage of wages, I wanted to make sure that folks are aware there is more detail behind how that was calculated. It doesn't just appear out of thin air. So what you'll see on this page, particularly if you're focusing on the rightmost column, is what we've built in for each benefit. So some things are pretty obvious because they're statutory. So FICA being the 6.2 and 1.45% of wages under federal law. Federal unemployment insurance is 0.6% on the first $7,000 in wages, or $42. So those things don't require much thought on our part. For pay time off, you'll see, again, if you look at that rightmost column for paraprofessionals, we have 25 days built in for the combination of holidays and vacation. For health insurance, we're assuming an overall participation rate of 75%, which I think it was with this group we had a fair amount of conversation about when we went through the provider survey results. So the data suggests, and I think everyone's experience will also acknowledge, that unless you're a very small organization, it's almost always going to be the case that not everybody chooses to participate in the health insurance coverage that you offer. They might have health insurance to their spouse, another payer like Medicare or the Veterans Administration, et cetera. So we don't assume that 100% of the workforce are receiving employer-sponsored health insurance, because that's just not the reality for most organizations or the workforce as a whole. And so what we're relying on here is, again, state-specific data published through the Federal Department of Health and Human Services Medical Expenditure Panel Survey, and finding a 75% participation rate in employer-sponsored health insurance. And then we have a mix of expenses based upon plan type. So an employee-only plan, a +1 plan, or a family plan. And again, the costs are derived from that main specific MEPS data, as are the individual mix of plans. So most folks in the state of Maine with health insurance through their employer are in an employee-only plan, for example. And then you'll see another chunk in the family plan, and the smallest cohort within the +1 plan. So that means for health insurance specifically, we're funding $600, about $600 per employee per month. That's not the cost for participating employees, but it takes into account that not everybody participates. And then, because other benefits tend to be offered on a more irregular basis, rather than coming up with assumptions and low participation rates for a lot of other benefits, we have a catch-all category that we label, not very creatively, other benefits, which is $200 per employee per month. And so once we take these assumptions and we convert them to a total cost, we compare that total cost to the total wage assumption, and that's how we get that 33.8%. So again, certainly open to feedback on all of these topics, but wanted to provide a little bit of background about the details that go into the numbers that you'll see roll up to the rate model itself. From here, moving past now the frontline staff, the other position that we specifically identify within the rate model is the clinical support or clinical supervision. So this is a licensed social worker type of position, is what we've assumed. If you look back to that Appendix A, which I quickly walked through, you'll see what BLS classification we're using as a benchmark. It's I forget exactly the terminology they use, but something like mental health, substance use, social worker, so master's level clinician, and the wage that we were assuming, just like we're doing for outpatient services under Section 65, is about $32 per hour. We're assuming that there are 6 beds for, a clinician covers 6 beds. So for every 6 beds, the rate model funds a full clinician. We're also including some on-call psychiatric support that we're reimbursing or assuming is a $1,500 per bed per year on average. And that's something that's derived as much as anything else from what we did back in 2015. So we didn't get a lot of additional data that suggests a higher number. Like everything else, if you have additional data that breaks that out for us, that's something that we can consider as part of the public comment process. Getting towards the end here, we built in a mileage expense. The number of miles per bed is a little bit richer than what was reported through the provider survey, but more in line with what we found back in 2015. So again, a small cost in the scheme of the overall rate, but something that we wanted to recognize because we do understand that that responsibility exists. And then that takes us to administration and program support. Just like we're doing for other services within this broader rate study, 13, 17, 28, 65, 92, we're funding a total of 30% divided between program supports and administration. You add all that up, we're left with a cost per bed of $3,900. And the last step that we're doing is assuming a average occupancy rate of 82.5%. So I mentioned there were some key assumptions. One of them was a total staffing level. This is another one. And what we're trying to recognize here is that you have to staff these programs even if a bed isn't always filled, which I wanted to differentiate from some of the commentary that came up earlier when we got together. If you can't staff a bed or you can't fill a bed because you don't have the staffing, there's not going to be the same cost associated with that, right? Because you don't have the employees that you're paying. What we're trying to recognize here is that there are going to be times when your program is operating, but someone is discharged. You don't necessarily have someone on a wait list to come in the very next day. So you're going to lose some billing revenue in those circumstances. And obviously that cost is still being incurred. You still have to have that staff because we're assuming that the staff is being shared. It's not a one-to-one support that we built into the rate model. So this assumes that a staffed bed where you actually have the staffing is filled about 24, 25 days per month. But that's used ultimately to inflate the cost. We're paying for those unfilled or those unfilled days to increase the total rate, which is then where we get to the ultimate bottom line of 677. So with that, happy to answer any questions that folks have, but that's the rate model that we have to present today. As we said, just a rate model, we don't have a mobile crisis proposal. And then similarly for residential, we're just assuming a single rate rather than any sort of differentiated or tiered rates. If there's no questions or comments, again, the materials we posted, I think likely by the end of the day today, although I'm struggling with multiple time zones. But I think we'll have that up by the end of the day today. Ultimately, this is being recorded as well, I believe, for those of you who want to go back and listen to our stirring overview. Once again, you'll be able to do so. Well, Olivia, I'm not hearing any questions.
Looks like there's one in the chat that just came through. How does the survey account for premium pay, like holiday pay, overtime, et cetera?
So in the survey itself, we're asking for the total wages inclusive of all effectively reportable income. So if you read the instructions for the survey, it asks for the total reported wages, which would be straight pay, overtime, shift differentials, bonuses, anything that's not a reimbursement of expenses, right? So that wouldn't include mileage or cell phone allowances, but it would be all of that again, income compensation. So when you compare what we've built into the rate model assumptions, the survey, that fully loaded wage report in the survey was about $19.50, and what we've built into the rate model is $20.40. If you look at the rate model, there is no specific assumption about a shift differential or any other sort of premium pay. It does reflect that median wage from the BLS data. So again, we're open to feedback on that topic, but as a starting point, the wage is already higher than the total loaded wage reported through the provider survey.
I think I heard you, excuse me, say in other calls that folks can ask questions, clarifying questions as well when they're trying to articulate a comment.
Absolutely. So during the comment period, we want to make sure you have the information that you need to offer fully informed comments. Right. So if there's something technical in nature about the rate model that doesn't make sense to you, how that 15% gets divided into the total expenses, for example, for the administrative rate, we're happy to answer those questions. If you want to have any questions about the data sources that we're using or need links to those data sources, we're happy to provide those. During the public comment process, we're not engaging in a back and forth negotiation. Obviously, that's not our role. But absolutely, if there's something that folks need in order to understand what the proposal is, by all means, reach out to us. And if necessary, we can certainly include the department in those conversations. But typically, that's more technical in nature, just calculations and data sources.
This may be
And to just quickly build on that point, I'm sorry, Sarah, that when comments are offered, we always tell folks that it's in our collective interest to be as detailed as possible. So you can tell us that you don't like the total rate, but that's not really going to result in anything that we can take action on, right? That's not giving us any specific feedback. What we're much more interested in is your commentary on, we think that wage assumption is inadequate, or we don't think the benefit package includes enough for health insurance, or something along those lines. And so not only being specific in what you'd like to see change, but if you have any data that supports your position, that also, I think, goes a long way towards us both understanding what's being suggested and determining whether or not there's a reasonable basis for making those recommended changes.
I just have a point of clarification. When is this proposed new bed rate to start? Maybe that's a question directed at the department.
I think I can answer that. So I
Thanks,
think
Steve.
we are, yeah, absolutely. So the idea and hope is that perhaps if we're able to have finalized rate models through this process in time, that we would take a look toward January 1st start date. I think that is dependent upon, this process going through its completion, which we are committed to doing. And so we are, really looking toward doing that. Now, in terms of what is the timing of rules, obviously we cannot do rulemaking without knowing what the rates are. And so the rulemaking is, it's going to be following. We're not going to be able to have a rule adopted and established for 1/1, for that. So we are looking at, potentially looking at a rate implementation date, being retroactive back to January 1st.
Okay. So my concern, right, if we have a hypothesized MHRT1 rate of 20, whatever it was, the screen's no longer shared, that is significantly more than some of our mobile staff are making. So with no rate change in mobile, my staff, they're going to go where they can get paid more. So that's going to be a challenge for somebody who has both mobile staff and CSUs, if one service changes and the other one doesn't.
Okay, Stephen, can I just ask one question about the children's rate? When you guys were looking at equating it equal to adults typically we don't put hands on. Children, sometimes we do, and we have to have if we only have one child in the unit, I have to have so many people in that unit in order to keep everything safe. And I'm just wondering if you looked at a TCI model or a MANTA model when you were deciding those figures about staffing ratios.
So generally, no, the assumptions that you see are what we publish on the page, the 1 to 2 during the daytime and the 1 to 3 overnight. We were partly constrained by not having a lot of feedback that allows us to do the type of analysis we would ordinarily do to see if there are meaningful differences between how an adult versus a child program are being staffed. So certainly open to your feedback about what you think would be an appropriate staffing level for children, if you don't think that we've hit the mark here. And again, if you have treatment models, MANTA or something along those lines that you want to provide information for contextualizing your comments, we certainly would be interested in reviewing that.
Yeah, and hello, everyone. I'm Peter Kraut, MaineCare's rate setting manager. To respond to Sarah's point, in sort of the best response we can give, which we know will fall short in some ways of what you're hoping for, is when we build rate models, it's basically saying this: we're covering the costs, the reasonable costs of providing a service. The department does not regulate how or what providers pay its employees, and so there's a lot of variation between what providers might pay the same employee. And so with residential, so even though the rates will be going up on the assumed wage of 2050 or whatever the exact dollars and cents were, the additional revenue that you will be receiving as a result, that becomes revenue for you as a provider to use as you see fit to reimburse all of your employees. So it's not to say that you must use all of it to make sure that your MHRTCs that are working on the residential side receive that wage. That rather was that was the wage assumed to go into the rate. If you have both services within your organization and it's important to you to preserve parity in terms of the wages that you're paying employees on one side or the other, there is that option available, that you could use some of the new revenue from the 1/1 residential increase, to provide raises to MHRTCs on the mobile side as well, pending the mobile redesign that Olivia alluded to at the top, and then the new mobile rate, which would be going into effect, as Olivia had said, target date towards the end of the summer. So I know that doesn't really give you a lot of what you're looking for, but just the note about the flexibility in how you can choose to deploy the funds.
Thanks, Peter.
Are there any other comments or questions or anything that anyone wants to add? Not hearing anything. See a chat. Okay. Thank you, Stephen. Thank you, Carl, for your work working with us today. But I think with that, we can probably look to adjourn and not keep your time too much longer. As Stephen noted, I believe they're going to be working to have the rate models up and available on their website, hopefully at some point today. And then let's see, Peter, I just want to ask, will your staff be sending out the information there, or should we just direct folks to the Reynolds? I just want to make sure that we've got close that loop before we close out the meeting today.
Sure, and Burns will be posting it at the same site that they had been posting, that they posted the survey. So, I mean, folks have that somewhere in their email. We don't want you to have to go looking for it and dig it out. So somebody here at MaineCare, once the new, once Burns has posted it, because there's no reason for you to be like going and checking, is it up yet? Is it up yet? We'll reply all to this email, letting folks know that it's there and just restating what the URL is.
Great, thanks, Peter. I appreciate that. And so with that, I think I just want to stress that we really look forward to and rely on your comments. So please review the rate models carefully and give us feedback. As it's been noted, rate models almost always actually, I think to a certain extent always, get some level of adjustment based off of comments. And, for that, we really rely upon you all. Certainly understanding that there is a holiday, period coming up, but in order for us to try to make a push for as close to 1/1 as possible, we've had to try to move things through as quickly as possible. And we definitely appreciate all of your time and energy focused on this. Work is ultimately we want to have rates that are fully supporting what you are able to do. So with that, I want to wish everyone just a safe and happy Thanksgiving holiday for those who celebrate, or just a potential long weekend if you're able to do that. We really just look forward to your comments and the process kind of moving forward. Thank you.